All right, let's admit some of our attendees. Good afternoon. Happy Friday. Thank you all for taking some time to join us over the lunch hour. We will get rolling shortly. Just give it a few moments for everybody to get logged in. And some of you may notice we're using a different platform. We historically have used Zoom webinar. We now have pivoted to Microsoft Teams, so hopefully everybody is experiencing this technology all right, no issues. Okay. Fantastic. So we are at the 12 o'clock. And Amy, if you would help me with the admitting while I am introducing Dr. Anastasiades, that would be appreciated. Thank you so much for doing that.
Absolutely.
All right, fantastic. Well, welcome everyone to our system-wide grand rounds. We thank you for joining us. I'm Dr. Francesca Varallo-Sims, Director of Education and Training for Baptist and Wolfson Children's Behavioral Health. Before we begin, just a few notes on today's presentation. If you do have any questions, you have two venues of sharing that. You can pop them straight into the chat or use the Q&A feature. I'll be moderating both throughout, so either venue is fine. If you are logged in through a cell phone that's not tied to your Baptist account, please go ahead and type your name and credentials into the chat. And at this time, I'd love to welcome our speaker today, Dr. Anastasiades. Dr. Maria Anastasiades is a fellowship-trained clinical health psychologist. She received her PsyD from Mercer University College of Health Professions in Atlanta, Georgia. Dr. Anastasiades is a member of the Society for Health Psychology, who provides psychosocial treatment for chronic health conditions. Dr. Anastasiades specializes in hospital-based care and has experience working as part of a multidisciplinary healthcare team. Her areas of expertise include life-threatening or terminal illness, behavioral pain management, coping with physical health issues, stress, and pre-surgical evaluations. Welcome, Dr. Anastasiades.
Thank you so much. Good afternoon, everybody. Happy Friday. Thank you for joining us today to talk about biopsychosocial treatment of pain. If you've joined this talk before, know that I've made some edits based on feedback, so hopefully y'all will still get new things from this talk. Next. I have no financial disclosures, unfortunately. And today we have 3 objectives. So I hope that all of you who are attending can describe the psychosocial factors affecting the experience of pain, can select and implement brief cognitive and/or behavioral interventions for patients with acute or chronic pain conditions, and learn skills for providing trauma-informed care for diverse patient populations with pain from a lens of cultural humility. So just kind of big picture, the impact of chronic pain, about 21% of US adults are experiencing chronic pain. About 8% of folks are experiencing high impact pain, which means it substantially impacts their ability to do everyday activities and work. It's one of the more common complaints in primary care and outpatient medical clinics. We spend a lot of money in the United States on healthcare related to pain conditions, exceeding our other kind of maybe most commonly known chronic health conditions. Also, the economic impact of lost productivity for folks who have chronic pain. Lifetime prevalence for patients with chronic pain attempting suicide is 5 to 14%, suicidal ideation 20%. So a fifth of folks with chronic pain are experiencing suicidal ideation. And then chronic pain, like lots of chronic conditions, can just become more complex over time. So that increases physical, mental health, and social impacts of the condition. So I think good reason for all of us to increase our skill and ability in managing chronic pain, no matter what setting we're in. So our definition of pain, this is the IASP updated their definition in 2020. That remains our current definition. So pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So that's our kind of working definition that we're using here. Some other important qualities of pain. Y'all can read these, but I want to point out that a person's experience, their report of pain as an experience should be respected. It's really important. And then verbal description of pain is only one way to assess and express pain. So we want to make sure that we're using lots of ways to assess pain for folks who are nonverbal or not able to verbally communicate their experience. Seems like a little deviation, but I think is relevant in everything we do. Cultural humility is really important to bring to the table as a healthcare provider in any setting. And so how do we define that? That's a lifelong process. You may have heard the term cultural competence previously. We know that kind of developing this skill is a lifelong process of self-assessment. It doesn't end. We don't one day become culturally competent. And so that's why cultural humility is a better descriptor of, I think, all of our duty as healthcare providers. So self-assessment with the goal of really building trust with folks and paying attention to the balance of power between healthcare providers and patients. The addressing model is an older tool, but a nice one to kind of tune into different identities and how those identities impact folks' experience of health and healthcare and wellness and illness. Folks who are women, individuals of ethnic minority groups, folks with obesity, folks with disabilities, folks with substance use disorders are less likely to have access to healthcare, and so may access the healthcare system through emergency services because that's what they have available. That includes having access for treatment for chronic pain, especially our kind of gold standard of integrated care, multidisciplinary care for chronic pain. As part of cultural humility, we want to be listening to folks' concerns to really pay attention to our own biases or expectations of what a patient's problem is so that we don't miss what they're actually telling us, right? What their real concern is. And it's critical to do that so that we can build this relationship with patients. And also because if we don't do it, we can negatively affect folks' health outcomes. So lots of good reasons to really tune into cultural humility, and particularly in the context of working with people with chronic pain. So SAMHSA has a really nice guide for trauma-informed care. I'm going to talk about this here too, as again, kind of setting the stage for like the mindset in which we can approach any patients, and particularly folks with a chronic pain condition. So trauma-informed care is critical to improve health equity, as folks from minority backgrounds are at a greater risk of experiencing trauma. And so here's our 4 key assumptions in trauma-informed care. So we realize how trauma affects individuals and communities. We recognize trauma, signs and assessments, signs through assessment. And here I mean sort of formal standard assessment as part of our processes. I know we do a lot of that in the hospital, and I've seen in outpatient, the social determinants of health screening include some questions there too. I'll add though that you don't need to know about an individual's trauma history in order to utilize trauma-informed care, right? So screening and assessment is at the organizational level, and you don't need to kind of inquire about folks' individual trauma history in order to use trauma-informed care principles. So responding appropriately, and then resisting re-traumatization. And this is sort of at the individual interaction level, as well as unit, clinic, organization as a whole. So how can we do trauma-informed care? What might that look like? Safety is the first one, right? What we know about trauma is that folks are sensitive to the experience of a lack of safety, right? Because of prior experience of being unsafe. So we really want to practice safety in physical settings. In practice, this can mean things like kind of verbally saying what patient care activities you're going to do before you approach a patient, saying a step in the care process before you do it, asking permission before touching, all of those kinds of things. I know there are certain settings, kind of emergent settings, where we can't always do that, but I think asking permission before touching folks is really important. Doing that helps us build trustworthiness and being transparent about what's coming. In some settings, peer support can be really helpful to kind of have folks with lived experiences kind of connecting at that level. Collaboration, partnering. So there's an innate power differential between a patient and a healthcare provider in any setting, right? And so that can in itself feel unsafe sometimes for folks, right? There's a level of vulnerability there. So collaboration is really critical. Building on folks' own strengths through empowerment, and then tuning into cultural, historical, and gender issues, and moving beyond stereotypes and biases. So between cultural humility and trauma-informed care, those are kind of the attitudes through which we approach folks, anyone, but particularly folks with chronic pain conditions. And I'll talk more in a bit why, including comorbid conditions. So from this slide, this nice little picture, I want to kind of give you a sense of the way in which there's kind of bidirectional communication between our peripheral nervous system and our central nervous system. Our kind of all the way down to our skin is collecting information and sending it up through our spinal cord, and then our brain is sending information back down, right? Which affects how our body responds. So autonomic responses, like how our blood vessels are responding, or somatic, how our muscles, our skeletal system is responding. And so that's a bidirectional experience. I think that's the most important thing to take away from this slide. Importantly, our brain processes pain in lots of different areas, and a lot of the areas that process pain also process emotion. So our prefrontal cortex, kind of our higher order thinking, reasoning, integrating information, kind of big picture, that's super important for both pain and emotion regulation. Same with the anterior cingulate cortex, pain, but also emotion regulation. Of course, our hippocampus processes memory, but also pain. And you can see how an overlay there can contribute to patterns developing in how the brain kind of intakes information and outputs information related to pain. So those would be the really important things to take away from this slide. So how do we assess pain when we need to rely on folks kind of report in some form or fashion? So everyone's seen the Wong-Baker scale. It's in everyone's primary care clinic with the faces, and so that's something that is a really easy, often used scale. In the hospital, 1 to 10, 10 being the worst pain of your life, 1 being essentially no pain, is the scale that's often used, including sort of pre-post medication administration. The FLAC is a useful tool for kids, for folks who are nonverbal, maybe folks with cognitive impairment or dementia, so that we're kind of tuning into all the ways that that person might be kind of demonstrating a pain experience, even if they're not able to use words. Measures of muscle tension and vitals can be somewhat helpful in measuring pain, although that's maybe a more indirect method. The McGill Pain Questionnaire is another really commonly used one. It's that questionnaire that has a body on the front, and folks kind of make a little X on the areas where they're experiencing pain, write some information about the medications that they're taking, and then there's also a few questions about functional impact of pain in different domains, which is really useful data. In pain-specific care, the pain catastrophizing scale is a really nice tool that can kind of prompt some nice interventions from a cognitive standpoint. And then in maybe pre-surgical evaluations or kind of appropriateness for opioid use treatment evaluations, psychological tests might include the Milan Behavioral Medicine Diagnostic or the MMPI. So I know we're still using the ICD-10, but the ICD-11 has done something really unique with the way that pain diagnoses are kind of organized. And so I wanted to share this to kind of give us a better sense of what's coming. I think this is a lot more helpful than ICD-10 really has pain disorder with psychological and medical factors as kind of the only category of, code to be used. And that's not always the most helpful code because it's so non-specific. So kind of pros and cons to this organization. To some degree, there has to kind of be a sense of the nature of the pain, kind of the nature of the origin of the pain, I guess. And so pros and cons there may not always be sort of a specified origin of pain. And sometimes folks can spend a good deal of time seeking that. And so that can sometimes, I think that could be a challenge in organizing pain diagnoses this way. But I think that the way they're organized here can help drive intervention in a really nice way. So chronic primary pain, either widespread, these are kind of subcategories of chronic primary pain, widespread, localized, other, or NOS. And so that's kind of our diagnosis of like a kind of chronic pain patient experience. Some unique settings kind of that can prompt some of those other diagnoses. Cancer pain is its kind of own unique experience, I would say, as well as kind of post-surgical, post-traumatic pain, neuropathic pain as well. Although kind of seeing them organized here, you can imagine the comorbidities folks may have. And so that might also give you an idea of other areas of this patient's experience you want to make sure you're assessing in possible intervention strategies as well. You'll see headache is also separated. Chronic headache is kind of another unique subcategory of pain that has some specific interventions focused specifically on headache, coping with headaches. Skip one? Yes, I did. An important one. So comorbid conditions, 67%, 2/3 of folks with chronic pain have a comorbid psychiatric disorder. So that includes depression, anxiety, PTSD, and trauma. Folks may have experienced ACEs, adverse childhood experiences. And so we want to really be mindful of utilizing trauma-informed care, even if we haven't asked about trauma history, right? Because there is a greater likelihood that a patient with chronic pain may have that in their history. Substance use disorder, including opioid use disorder, alcohol use disorder, some of those other conditions. Smoking is a kind of comorbid tobacco use disorder. Certainly insomnia is a very frequent concern for folks if you've ever seen a chronic pain patient, and all of us have, most likely. Unfortunately, pain is so disruptive to sleep for lots of reasons, including the pain itself, and maybe activity limitations, so not feeling as maybe brain tired, although the body is tired, even medication side effects too. Cognitive changes, so kind of sort of an acute transient change related to the pain itself. So our attention, of course, is going to be redirected to the pain during a pain episode, and that's going to make it hard to attend to other things. Certain medications have side effects as well, including kind of brain fog, and that's largely reversible depending on coming off of that medicine or even multiple medicines. Also, risk of Alzheimer's dementia is a commonly comorbid condition for folks with chronic pain and sexual dysfunction. And so all these kind of different areas are really important to consider, if not kind of screen for directly when thinking about a treatment plan for chronic pain. So setting the stage for treatment, right? With like the McGill Pain Questionnaire that has some of those pain sort of functional questions, identifying goals related to function as well as pain reduction is really critical. There are some folks I've worked with where their pain maybe doesn't change, but they're able to sort of their number on a scale of 1 to 10 of pain doesn't change, but they identify functional improvement. And I view that as a success. They view that as a success, right? And so setting goals related to function as well as reduction in pain. 0 out of 10 is not a goal that's reasonable. So if we set ourselves unreasonable goals, we might be really disappointed when we don't meet that. So pain is a part of life, unfortunately, particularly with some of those comorbid physical or mental health conditions. And really assessing the functional impact of pain at work, at home, in caring for yourself, managing healthcare, interpersonally, all those different things is really important because that can give you a lot of data about goal setting and tracking improvement over time. Multimodal and interdisciplinary treatment is best practice. I know we've got a lot of different disciplines on this talk, so we all kind of know that that's our best practice here. Again, recognizing that there are folks come from minority backgrounds or underserved under kind of resourced backgrounds who don't have access to that necessarily, particularly in the outpatient setting. And so we can potentially offer that even in the emergency room or in acute care, and kind of utilize our resources to maybe get folks what they need, even if it's piecemeal. So we have an opportunity there. So as a psychologist, I'm not a prescriber, and also I have to be really aware of all the different treatment options, as any of our folks who are on the call who are not prescribers, kind of being aware of the options is really, really helpful. So we might be able to kind of learn from folks, what their understanding is of what medicines they're on, how they're working for them when they're not working, how the patient's using them too, because that can shape how effective or not that those medicines might be. So our non-opioid analgesics, NSAIDs, like Tylenol, Advil, those sorts of things. That's a commonly used one and a really appropriate tool for folks. I know in the hospital setting, it's kind of for like, 0 to 4 pain and, categorized as one of those like milder pain kind of and more broadly available to more different patients because generally has a lower risk profile than some other medicines. Opioid analgesics, so those are synthetically produced. They can be short or long acting, which means, which is dependent upon how quickly our body is processing those medicines out. Unfortunately, they have a lot of side effects like nausea, constipation, drowsiness, like some of those cognitive changes that can happen for folks. Because of the nature of the kind of chemical compound of these medicines, they're really associated with a higher risk of misuse and physiologic dependence, unfortunately. So they are an appropriate tool for folks in lots of different situations and have risks to be mindful of. Tramadol, so that is another commonly used one in the hospital, especially. It interferes with transmission of pain signal like an opioid, but releases norepinephrine and serotonin like an antidepressant. Some of the topicals like diclofenac gel, lidocaine patches, often muscle relaxers are used. Many folks kind of have a lot of muscle tension as either sort of one of their primary pain conditions or related to a pain condition. So these medicines are used in that capacity, including diazepam, which is a benzodiazepine, but also used as a muscle relaxer. Additional medicines, so TCAs and old school antidepressants like nortriptyline, amitriptyline are used. Often duloxetine is another really commonly used one, actually venlafaxine as well. And then gabapentin and pregabalin are additional tools often used, particularly for neuropathic type pain. The medicines in that category are often applied in the context of neuropathic pain. Some specific headache medicines, topiramate, sumatriptan, those are ones that are either taken as preventives or abortives. In the hospital, Fiorcet is another one often given. And then I listed buprenorphine here, which I think is I'm I'll call y'all's attention to it because it is a tool that's used for pain management. And so when you see folks who have it on their medication list, maybe to kind of inquire non-judgmentally about the purpose of that medicine, because yes, it is used for opioid use disorders, but it's also used for primary pain conditions as well. So I think using really a non-judgmental inquiry there can be really helpful in understanding the role of that medicine in someone's history and relationship building. Some other treatments that folks often receive: steroid injections, nerve blocks, spinal cord stimulators are actually implanted, and they deliver electrical pulses that mask and or distract so the pain signal is not perceived. If you think back to the picture about kind of how the nervous system is bidirectional there, by interrupting kind of input that can change the pain experience up in the brain. Interacting input at the level of the spinal cord can affect how the brain is responding, is receiving or not receiving those signals. Intrathecal pumps also implanted, deliver pain medication right into the spinal fluid. Surgical procedures, TENS, which can, again, almost offer like a nervous system distraction to change the perception of pain, interrupting that neural impulse up to the brain. Heat and cold are really, really good tools for lots of different folks to change sensitivity or relax muscles. For folks who have spasticity, Botox injections are sometimes used. And then certainly positioning in the bed or the chair, using pillows, a foam wedge, those sorts of things. I've seen folks who, they need to stand every 10 minutes and they need to like spend 10 minutes sitting, 10 minutes standing, and kind of go back and forth. And so doing that in session is totally fine with me if that's one of their tools that works. Additional therapies, certainly physical therapy to increase strength, range of motion, flexibility, conditioning, super important, particularly if folks have gotten into a pattern of kind of pain, avoidance of movement, more pain, more avoidance of movement. So physical therapists are really skilled in kind of creating a new pattern there, kind of disrupting that pattern. Even using mobility devices as needed certainly can be tools to help kind of folks, again, work on functional goals and make gains in that domain. Aquatherapy is a really good one that people seem to enjoy. It's kind of low impact, good for folks maybe who are older adults, have arthritis type pain, those sorts of things. It's a really kind of gentle way to increase movement and mobility. Massage, certainly too. Dry needling as well, also done by physical therapists. And then certainly occupational therapists are really excellent at helping folks figure out creative ways to complete their daily living activities, again, using adaptive equipment as much as is needed, with the goal of increasing function, which, as I said, should be part of the treatment plan when it comes to managing pain. Other lifestyle interventions, so dietary changes can help some folks, especially sort of like considering maybe anti-inflammatory diets, things like that. Person dependent. I would just kind of caveat that weight loss alone is not an appropriate intervention for pain, right? Because those are kind of related conditions, but weight loss doesn't specifically address folks' report of chronic pain, right? And not to mention that weight loss is a long-term goal for many folks. So dietary changes can go alongside other direct treatments as well. Yoga, acupuncture, chiropractor, I think those are things that can be person specific. And if someone really appreciates them in their own life, by all means, use what's helping you. So some kind of evidence-based treatments in the realm of health behavior and psychological treatment. Self-management is actually a really appropriate intervention for chronic pain, educational groups. There are a lot of apps out there, actually. My national organization is collecting a list of apps that are used, and I've already seen 3 really good ones so far on the list. So if you can reach out to me directly if you're interested in that list. Lots of kind of workbooks for folks to work through on their own, usually either acceptance and commitment therapy or CBT, cognitive behavioral therapy based. Education itself is also a really powerful intervention. So learning about how the brain and body kind of interact with each other to collect information about sensation and make sense of it is really, really helpful. I think the education too can focus on our brain's ability to create patterns, to learn patterns. And sometimes it's so good at learning patterns that it may create a pattern that's not as helpful as maybe another pattern might be. And so the options for treatment are about teaching your brain new patterns. All that can be super helpful. Of course, chronic pain, CBT specifically for chronic pain, mindfulness-based stress reduction, hypnosis is an evidence-based intervention for chronic pain, acceptance and commitment therapy, biofeedback, and a newer treatment is emotional awareness and expression therapy with some really interesting results for veterans with comorbid PTSD. Again, kind of that treatment is focused on the overlay between how our brains learn patterns about safety and danger, both kind of in an emotional context and also in a physical symptom context. So just kind of in brief, the background, the theory behind CBT. So our thoughts, emotions, and behaviors interact with any situation. I think probably each of us, if we reflect, have like experienced this real time, right? So an example might be, so neck pain is felt with mowing the lawn, so that's a situation. They may get scared and think, oh, something's wrong with me. Their behavior then is that they avoid moving, lying on the couch for the rest of the day, and may even avoid mowing the lawn in the future. So might not even go back to doing that. So we can kind of potentially act on any one of these components and create change. This is a really busy slide, but I'll kind of put that out there to acknowledge how many layers exist when you think about kind of how a chronic pain condition evolves, the kind of things that maybe reinforce that experience, and kind of the challenges you might be up against in treatment. So many layers, kind of intrapersonal, interpersonal, and then at like the kind of community level, at the healthcare level, at the financial, insurance, medical, legal level. So a lot of different layers there to take into account, to pay attention to when you're thinking about assessment and intervention and treatment planning for folks with chronic pain. So this is a really helpful kind of part of education for folks. So this is our gate control model. The gate in the middle there is sort of our nervous system, right? And so there are things that open the gate to let pain signals through. Depression, anxiety, fear, focus, so attention to the site of injury, feeling out of control, other negative thoughts, and withdrawing. So those are the things that open the gate. When the gate's open, more pain signals are allowed to pass through, and that increases the experience of chronic pain. Factors that close the gate, this is kind of our opportunity, right, in terms of treatment. Being able to manage our emotions. Remember that parts of the brain that mitigate emotional control also manage pain sensation and interpretation. So control of emotions can help that gate close a little bit. Relaxation, distraction, focus away from site of injury or site of pain, different kinds of thoughts, a sense of like agency, and then a sense of achievement, engaging in things that are really enjoyable. So this is kind of a maybe teaching tool, as well as can guide potentially goal setting and guide treatment as well. a lot of things to talk about here, and I'll just briefly touch on a couple because I do want to make sure I have time for my cases towards the end. I think one of our challenges is hurt versus harm. And that's a really useful strategy to kind of a really kind of opportunity for education, and to be done, I think, intentionally, so we're not invalidating folks' experience. But then there is a difference between the sensation of hurting and harm happening to the body, right? If we think back to the definition of pain, um, you know, it is causing an injury, or like it could feels like it caused an injury, right? And so there's a difference between injury and the sensation of hurt, right? Those two things are different. The opportunity is with feelings of hurt without injury, we can work towards improvement there, I think, right? Without needing to necessarily pursue surgery or a cast or something like that, right? Behavioral factors, lots of opportunities for change process here. One of the things I use so often is activity pacing. So the key to activity pacing is setting your rest and work breaks before you even start working, and holding yourself accountable to that. So you're resting before you need to rest, and that way disrupting kind of that overwork, need to recover for a day, sleeping kind of a lot for the next day, needing to lay in bed for the next day, and losing a day, right? So pacing is a really, really nice tool that I think a lot of folks can implement. It really resonates with them too, to kind of say, hey, a lot of us really, we're go-getters. We want to stop when the job is done. And the cost is then you lay in bed for a whole day, right? Having to recover, and that's really tough. That feels worse. And so here's kind of a tool that you could implement today, to kind of still have achievement, still have accomplishment in your day, and not need that recovery period. So you can have achievement tomorrow and the next day and the day after that. So that's a really helpful tool that I think a lot of people resonate with. So mindfulness-based interventions, specifically mindfulness-based stress reduction, was one of our first kind of non-physical treatment for chronic pain. Back in the late 1970s, John Kabat-Zinn did this really nice study of folks with treatment-resistant chronic pain. The intervention was kind of mindfulness meditation, mindful movement based, relaxation, all of those really nice tools using things like a body scan. And I think what's really helpful is that intentional awareness to the present moment without judgment. Really hard work, and also a really, really helpful tool for a lot of folks. And mindfulness is built into a lot of the apps and workbooks and things like that as an important component of chronic pain management. Motivational interviewing is a nice, again, kind of attitude to take towards treatment planning and treatment with folks with chronic pain. Really collaborative, goal-oriented, focusing on kind of what is a person's motivation, what is the patient's motivation here. And so this is hard work to change how our brains, the pattern our brain has developed. And so they've got to kind of figure out their own motivation there too. It's also respectful and kind of rolls with resistance, right? We're kind of offering our expertise, and we have to kind of acknowledge when folks are maybe not ready for a certain type of change process, right? And really kind of figure out what could get them there. What would it look like for them to be ready for change? Importantly, given that 2/3 of folks with chronic pain also have other mental health conditions, treating those comorbid conditions is so critical to kind of improving function, I think, across domains. So, and a lot of the treatments for depression, anxiety, even trauma can be tools that are kind of multi-purpose. They can be used also to manage pain symptoms, kind of pain cognitions, interpersonal impacts of pain. So all kind of these tools for anxiety, depression, and trauma are important to kind of say, let's apply them broadly, right? If this tool is working in this domain, let's see how we can work in another domain. And also considering medication management of symptoms related to these conditions too. Comorbid substance use disorder is a really, really important consideration. So opioid use disorder specifically has really high impacts on folks' health and function and family life and communities. Certainly co-occurs with chronic pain and including pain that is treated with opioids, unfortunately, which makes it really challenging because both conditions have to be treated sort of simultaneously. There's a really nice kind of opioid calculator for the morphine milligram equivalents, which is really helpful to take a look at. There are significant risks of overdose increase if the morphine milligram equivalent is equal to or greater than 50. And so that's a nice tool to kind of, it lists all the different medicines you can put dosing in there, how often it's taken per day, and get a total morphine milligram equivalent. So in long-term opioid use in chronic pain is associated with worse outcomes, unfortunately, greater disability. Both conditions, both chronic pain treated with opioids and opioid use disorder are really challenging to treat without buy-in from the patient and the physician and the prescriber. I know we have excellent addiction medicine folks on the call, and I know even folks in primary care find themselves kind of managing some of these conditions as well. But weaning too quickly increases risk of suicide. And so kind of folks' lives are at stake here, right? And so this is a really challenging kind of clinical situation. And so involving everyone who could be helpful, I think, is our best bet, right? So addiction medicine, so our specialists who treat kind of the opioid use disorder, psychological treatment, address physical health symptoms, address social issues as best we can, and really kind of take a whole person approach. A couple of other kind of physical health conditions that can be comorbid and can also be opportunities for intervention as well. Insomnia specific treatment is super helpful, considering cutting back alcohol use, physical activity, again, using all of our disciplines to work together for these folks is really helpful. So in the last few minutes that we have, I, based on feedback from last year, wanted to add a couple of cases. So I've got one inpatient and one outpatient case. I can't see the chat, but I'll just read this aloud to you guys, and I would love for folks to just use the chat and offer questions or feedback or ideas for this case. So first we have John. He's our 70-year-old male veteran, hospitalized for shortness of breath. His history includes PTSD, chronic pain, and COPD. He's married, lives with his wife, currently smokes 1 pack a day and denies alcohol use. He's got a VA psychiatrist and is on Cymbalta, trazodone, not currently in psychotherapy. So he's here in the hospital for one reason, but is having more chronic low back pain due to the hospital bed. Y'all, I'm sure have heard this too. Those hospital beds are sometimes really uncomfortable for folks for lots of reasons. What ideas and strategies do folks have about how John could better manage his discomfort during the hospital stay?
Doctor, as any responses come through, I'll read them out. So
Thank
we
you.
have, of course, inpatient physical therapy as a potential option.
Absolutely. Absolutely. Totally agree.
Positioning and frequent changes.
Absolutely. Positioning is a really helpful one.
Going further, perhaps giving some psychoed and distraction-based coping.
Absolutely. And sometimes we have to suggest that, like, hey, I know the TV has limited channels compared to our TV at home, but are there any channels that are good on here? Maybe listening to music on your phone, cell phones, things like that, calling a friend. sometimes we have to give some options for distraction in the hospital.
Mhm. Another one is, it looks like these are along the same lines, these two comments. So mobility, repositioning, and engaging in purposeful activities.
Absolutely. Absolutely. And that kind of does twofold, right? So movement certainly can help. And then engaging in a purposeful activity is also a nice distraction, kind of closes the gate a little bit, as it
Mhm.
were.
Absolutely. And then heat therapy, lidocaine patches, engaging in talk therapy to talk about frustrations related to pain.
Sure. Absolutely. All of those are awesome strategies. And I think importantly, help us say to John, John, we hear you. We hear that your back hurts, and we know that our hospital bed here is not the same as your nice Tempur-Pedic at home or whatever the case may be, right? And so we're really listening and responding with kind of active treatment. Yeah.
Mhm. A
Any
couple
others?
others
Yeah.
is meditation, guided imagery, and occupational therapy.
Absolutely, to all of those, certainly super helpful to kind of get him moving in his daily life activities, right? Maybe get to the bathroom and wash face, do some brush hair, do those things that make you feel more like yourself in the hospital certainly is helpful.
And believe that was the last comment.
Okay. Thank you guys so much for your responses. I really appreciate, um, using all the strategies you're probably already using. Maybe this conversation is added to that too. So we'll go to case number 2, Sally. So Sally is a 68-year-old widowed female. She's presenting in Agewell Clinic for her routine follow-up. She has a history of hypertension, diabetes, and also depression/grief treated by her primary care doctor with some Zoloft. She's not in psychotherapy now, but has been in grief counseling in the past after her spouse's death 5 years ago. So she's having an increase in her neuropathic pain that's affecting her feet and at times her ability to get up and move around. What are some additional recommendations you can provide to Sally to help her better manage her pain?
This one was tied to, it came through a little bit later, but I feel
Sure.
like it is relevant for this one too. So, in terms of motivational interviewing and the question specifically, what can we do that you feel would help relieve your pain? So, putting
Mhm.
it back in the hands of the patient so that they can exhibit, some control, because
Yeah,
as what you've alluded to, they can feel out of control, in many of these
absolutely.
cases.
Absolutely. I love that. And that also adds kind of that again says, we're hearing you. Like, what is your understanding of what helps you? And I think that's a really kind of inclusive approach to saying, hey, what do you understand about your pain and what makes it better or worse? And that way we can kind of include his input too. And I would agree. I think that's applicable here for Sally.
A few others, so CBT, PT, aquatherapy, acupuncture, but the poster noted cost limiting, right? So we have to take into
Sure.
consideration SES and, like you noted, the social determinants of health per patient.
Mhm.
Gabapentin, if not contraindicated, support groups, slow flow yoga, and again, pointing to asking what the patient, would make them feel better.
Yeah, I love all of those suggestions, including kind of tuning into um, what's actually available to the patient, right? Y'all probably already know this, but um, so the YMCA is really accessible financially to lots of different folks. Sometimes Medicare will even cover the YMCA membership too. And so they have silver sneakers for older adults and do a lot of really nice groups and water aerobics and things like that through that program, just which kind of maybe hits on some of those suggestions too. They even have like kind of more affordable things like massage therapy and things like that through the YMCA too, but really appreciate noting that like we got to see what this patient is kind of able to reasonably do and to take care of herself based on her SES background. So thank you for that.
Mhm. couple more that have come through. OT, occupational therapy, support groups, massage therapy, referral to local counsel on, again, Dr. King, I'm not sure if that came through correctly, but give us a qualifying statement of what we're referring to, because I'm not certain. Oh, aging. Oh, yes, got you. So Sheila helped out. Thank you. So the Council on Aging, absolutely. That's an incredible
Yeah.
resource as well.
Yeah.
Um, there is a question, if you're okay with it, Dr. A, I
Sure.
will pose it to you so it's in line with here. Some patients are resistant to all the suggestions. How do we handle the
Mhm.
resistance?
So you'll remember from our MI slide, kind of rolling with resistance and saying, here's the menu of things that I can offer you. And sometimes folks say none of those things work for me. And I really think that's an opportunity to say, well, what has? What has worked for you? And sometimes folks will say, well, really nothing's worked for me. And kind of I then tend to explore like, what would it look like if this pain went away? What would you be doing? Kind of how would you be feeling? What would that be like? And sometimes we can find other ways to meet goals, like functional goals, or maybe even like emotion related goals or social engagement related goals. Um, that are kind of like if this pain was reduced, if we were from like a 9 to a 5, right? What would you be doing? How would you be feeling? And sometimes that can kind of get us another angle to approach the change process, right? And sometimes kind of we have to say, here's a menu of options, maybe it's a long menu and you kind of say, I would love for you to look at this menu of options, come back in 2 weeks and kind of let me know what you've checked off of these options as things you think might help you. And sometimes that can start to drive even the tiniest amount of change process that way too. It's tough. It's really tough.
Mm-hmm. We had a couple more. So
Mhm.
mindfulness, meditation, and relaxation techniques. Those seem to be good for many different heat and cold
Yeah,
therapy. Related to the localization of this case, a podiatry potential referral
yeah,
or pain management. Gait training. So again, pointing back to where the pain is occurring. And a follow-up qualifying question is
sure.
when asked about what will work for you, they'll say, that's why I'm here to find answers. Okay, so a little
Yeah,
opposition. So
yeah,
what's our follow-up?
yeah. That's a really good observation. I think our relationship with the patient kind of is what gives us options to go forward to, right? And so even just learning more about when did the pain start? How has it affected you? How has it changed over time? What prior treatments have you tried? Tell me kind of what worked about them, what didn't. Maybe there were parts of certain things in the past that have worked for you and that haven't. And then reiterating like, I'm here to help you and kind of here's my menu of options that I usually can offer to folks, right? Let's see if we can work through this menu. Or again, kind of take the menu home, think on it. Let's have another visit in 2 weeks or whatever. So to give you some time to process our options. And then we'll kind of keep making a game plan from there. But I think the relationship with a patient, keep continuing to build that can sometimes give you an opening when it seems like there maybe isn't one there, right? And I also share with folks like, you're the expert on you, right? You're here for my expert opinion, and I'll certainly share that with you. These are the ways in which chronic pain is most often treated, and you're the expert on you, right? You're the expert on what it feels like, how treatment is working, and also on kind of how the pain is affecting your life and maybe setting some goals about, again, function as well. And so we're collaborating experts here. And sometimes I think that can help to, again, build that relationship so we can find a tiny window over time of opportunities for change.
Yeah, that's a really excellent point because, and in your experience, have you found it in their history, they have been invalidated about their report
Mhm.
of pain, which makes them potentially distrustful, you know what I mean, of folks that they're worth, even
Certainly.
other medical professionals. So yeah, I think building that support and garnering their trust in your ability and your genuine care for them is
Right.
probably, one of the steps to reduce some of that response.
Certainly, certainly. Unfortunately, I think, and I think some of that validation is really inadvertent on the part of our kind of system as a whole and the way that it's organized. And so it can be inadvertent in validation, but I think validating folks' kind of experience is a really nice starting point to build a relationship and kind of go from there.
Yes. So one follow-up is,
Sure.
are there any particular recommendations for individuals with advanced primary progressive MS?
That's a really good question. Um, I would imagine that those folks have kind of a unique pain experience. I would imagine like neuropathic pain, maybe even muscle spasticity kind of experience. And then also the functional impact of advanced MS, right? I mean, needing to utilize caregivers in lots of different ways, a major functional change for many folks. And so I would imagine that kind of and folks don't want to say, I'm not depressed, I'm not anxious. Sometimes I'll just kind of acknowledge this is a really big adjustment. This is a really big change. And I see you like learning new skills to use your voice to manage caregiving and medicines and doctor's visits. And so certainly it's an adjustment. And sometimes folks will kind of agree with me there. And so kind of maybe tuning into like the adjustment piece as well as the pain specific symptoms could be really helpful. And seeing what's important to the patient. Maybe they're like, I really want to sleep. It's like, okay, that we can work on, right? That we can kind of figure out a plan to work on what's most important to them, what symptoms are most important to them to really focus on. I hope that's helpful.
Thank you. Another question, in terms of any thoughts or research that you've been exposed to on the use of cannabis to manage pain, many patients report, prescription and non-prescription cannabis to relieve pain and secondary symptoms related to pain, i.e. poor sleep. So just any thoughts on
Right.
that?
Right. We don't have great data about cannabis. Unfortunately, its current schedule classing federally is limiting to the kind of research that can be done. Um, there's not great data out there to support the use of cannabis in pain management or anxiety. Um, I guess sleep, I could imagine it's can make you a little sedated, although it can also have the rebound effect of kind of anxiety. So I think it's very person dependent. And my kind of approach and attitude is if it's not medical marijuana, like what are the other potential risks? What are the potential interactions? Are there any downsides, like socially or work-wise or cognitively that you're noticing from using this as a tool? And some people are like, no, I take one hit before bed, I go to sleep, I wake up, I'm awake all day, I don't use during the day at all. It's my like bedtime only routine. It's useful in that situation. I'm like limiting dosing and timing and things like that. And then I think it's sort of person dependent, right? I do always say there's not clear data that it is an evidence-based treatment for pain or anxiety or sleep. It's kind of more of a kind of N of one of the person in front of you and how it works and what the potential downsides or risks are in using it. And just encouraging them to kind of be clear with their other providers so we're not having any medicine interactions as well.
Yes, and I think we'll have time for about one or two more questions as they
Okay.
come through. So I'm sorry if you did have another case, we dove right in.
Nope, that was it. All I had was my
Okay.
summary slide and then my additional readings, but y'all will see this get the handout. So
Okay. So how would you recommend making patients more aware of their psychological components, anxiety, depression,
yeah,
when they seem to be in, denial, not accepting of this potential fact?
sure. Sometimes using questionnaires can be helpful because that gives us like kind of objective data, right? So sometimes a PHQ or a GAD are free screeners for mood symptoms. You could utilize those. Again, I think focusing on, hey, how is this pain affecting other parts of your life, right? Your ability to, to work, to be a parent, to be a partner, to manage your home, to go to school, like kind of focusing on that. And even kind of asking about symptoms related to adjustment can sometimes be my in, right? And so I'll say sometimes as folks are adjusting, they find that they're like, can't sleep because their brain won't shut down, or they find that they're just like really dragging even though they've slept enough hours, or their appetite's kind of not what it used to be, or maybe they're kind of stress eating. And so I'll throw out symptoms like that instead of saying, are you feeling depressed or are you feeling anxious? And then I can kind of use those symptoms to guide treatment planning to like, okay, well, we'll want to see you kind of build some skills to be able to fall asleep without those worries keeping you up for an hour, right? To have strategies to wind down before bed. And so sometimes asking about specific symptoms can get you in there sideways if people are kind of not identifying as depressed or anxious.
Absolutely. Oh, this is a good, one second, sorry, final question to end on potentially, because it's tough to work with any patient population, but especially those that experience chronic pain. It is tough for the provider as well. So the question is how to handle our own frustrations with time constraints during patient visits to ensure, we're maximizing and giving them all the tools and resources.
For sure. I sometimes will set like a agenda with folks if I'm doing really brief interventions and kind of say, hey, we've got 15 minutes. I get I'll set a timer for 5 minutes of just checking in on things. We'll spend 5 more minutes and the timer will go off to kind of catch us. And that way we can set aside kind of time for each of our things on the agenda. Did I get lost? Okay. My screen just lost itself.
You're
So
good.
yes,
You're good.
using the agenda I think can be really helpful, and then have colleagues that you can talk with, right? And kind of share your experience as a provider because it is not easy work. So do have colleagues you can consult with.
Fantastic. Thank you so much, Dr. Anastasiades. So for everyone, this is the QR code that you can scan if you are on a desktop. If you are on your phone, you clearly cannot do this. So you can just click the link that I've included in the chat, and always feel free to reach out to GrandRounds@bmcjax.com if you guys have any questions. And also if you would like a PDF of the slides. Further final note, we will upload this talk to our YouTube channel, which is also linked in the chat. So check that out when you guys have a second, and really appreciate everyone attending. Again, thank you, Dr. Anastasiades, for providing this valuable information, and we hope to see you guys at our next event. All right. Have a wonderful weekend. All right. Bye-bye.